Welcome to the Friends of AHRQ, the Agency for Healthcare Research and Quality, the Friends of AHRQ special briefing to celebrate 20 years, the past, present, and future of better care at better value. We have a terrific panel of experts who will talk with us about the work that they've done and their thoughts about the future. But before we do that, I'm going to introduce a special guest, and I forgot to introduce myself. And I am Lisa Simpson, the President and CEO of AcademyHealth. And today has some special meaning for me as well, because 20 years ago, not exactly today, but 20 years ago when AHRQ was created, I was the Deputy Director. So I consider myself an alumnus of the agency as well. So our special guest today is Director Khanna, Gopal Khanna. We are honored to have you join us and say a few words about the agency. Thank you so much.
Thank you, Lisa. Thank you so much. You've been such a great supporter of AHRQ, and I want you to know that we are extremely grateful for your support, as well as we want to appreciate your organizing this event. And I will say that this is an extremely important event because it celebrates a very important milestone, 20th year of finding of AHRQ or establishment of AHRQ. So that's really awesome. Well, milestones like this one, anniversaries like this one, give us an opportunity to think about the past, the present, and the future. And it's important that we take a moment to thank the people who have made this success happen for us. So let me start by expressing my gratitude, first and foremost, for our ongoing partnerships with stakeholders, the excellence and willingness and diligence of the investigator community, and for superb staff at AHRQ. I also want to recognize the inspired leadership of AHRQ, which was provided by great and exemplary directors like John Eisenberg, Karen Clancy, Rick Cronick, and Andy Beinman. Thanks also to our great collaboration with our partners. Today, as a result of that, AHRQ has become the premier funder of health systems research, which has led to substantial improvements in the delivery of care in America. We have made a positive impact on the safety, quality, equity, accessibility, and affordability of healthcare. Historic milestones, like the ones we are celebrating today, also provide an opportunity to think about the future and a path forward. As you all know, the world of healthcare has changed dramatically over the last 20 years, and the speed of change is accelerating rapidly. Having said that, if you take a moment and reflect, the nation's healthcare landscape is being redefined by major disruptive forces at play. So just to talk a little bit about them, mergers and acquisitions, infusion of new technologies, Internet of Things, digitization of everything, shifting demographics, and how can one forget the volume and variety and velocity of data flowing into the system. The challenges before us are huge, but opportunities are even greater. I believe AHRQ is uniquely positioned to improve the lives of patients in our ever-changing digital healthcare ecosystem. Through conversations with frontline clinicians, health systems leaders, policymakers, and researchers, AHRQ has identified 3 critical challenges that are front and center in today's healthcare environment. They are, 1, improving care for patients with multiple chronic conditions. 2, reducing the error rate of diagnosis. And 3, ensuring the availability of data and analytics to capture a 360-degree view of the nation's healthcare system. Now, addressing these challenges will require AHRQ to build and leverage our core competencies in 3 areas: systems research, practice improvement, and analytics. And for all these 3 challenges, the solution begins with cutting-edge health systems research to discover new knowledge and provide needed evidence to optimize the quality, safety, and value of care that patients receive. You see, cure and care are two sides of the same coin. A few years ago, Congress passed the 21st Century Cures Act to bring us the cures of the 21st century. My belief is that the next frontier is to bring to the American people 21st century care. That is our future. Thank you, ladies and gentlemen. Thank you, Lisa, for inviting me. I appreciate it, and have a great day.
Thank you so much, Director Khanna, for joining us today, and as you said, for the partnerships that you have established here and throughout the country. So the format for this afternoon is I'm going to make some brief remarks and introduce our speakers, and then they each will speak for about 10 minutes, and then we'll have a little bit of time left for Q&A. As we mentioned, we are on Facebook Live, which is certainly my first time on Facebook Live, so that's fun. To begin, I want to do my first round of thanks for our supporting partners in the Friends of AHRQ and who are bringing this briefing to you, and you can see them listed here. And it's really through this coalition, the Friends of AHRQ, that we are able to raise our voices in unison to support the important work that this agency does. Now, as has been already mentioned, we are going to cover the past, the present, and the future of the agency. We know that AHRQ has improved our understanding and responses to issues that have been pervasive and challenging our healthcare delivery system. For AHRQ to continue to do this and be successful in the future, it needs stable, predictable funding to ensure it can deliver on that mission. And as we look to the future, AHRQ is critical to the nation's ability to respond to the future challenges, just as Director Khanna mentioned, whether that's multiple chronic conditions with the aging of our population or the potential in data analytics. These are critical directions, as well as the enduring focus of the agency on patient safety, now through an added focus on diagnostic error, which you'll hear more about from one of our speakers. So I hope you all know that AHRQ drives these improvements in patient safety, in primary care, in data analytics, and other areas by focusing on improving care's accessibility through data, through improvement, through research. It also makes its work and its support of tools and opportunities to disseminate and implement good research makes healthcare safer. It also helps care become more effective. We don't want to know just what works, but what works for whom, under which circumstances. We know so well of the pervasive and enduring disparities in care, whether that is due to geography, to race, ethnicity, language, or socioeconomic status. And finally, and importantly, making care more efficient. When we talk about value, we need to understand not just the benefit, but also the costs. And AHRQ has been a key resource in helping us understand and evaluate the efficiency of the care system. So our core message to you as the voice of the Friends of AHRQ is that right now it's about funding, right? Any conversation on Capitol Hill, we cannot achieve our mission, we cannot achieve our goals of better care at better value if we do not have the resources. And currently the budget for the agency stands at $338 million for fiscal 2019. But if you look at the long term, the agency's purchasing power has decreased by over $150 million since 2010, so in less than a decade. And also additional capacity that was built up during the stimulus funding for comparative effectiveness research was also lost when that expired. But we know that lawmakers here in Washington see the value of the agency's work. They have rejected repeatedly the administration's proposed cuts and consolidation into the National Institutes of Health. They have enacted 2 consecutive years of increases in the budget, and this year are proposing the largest increase of $20 million in more than a decade as part of the House Labor HHS bill. So the other thing that I want to really flag for everyone is the fact that the agency could lose about 1/5 of its budget on September 30th because it is now coming from the Patient-Centered Outcomes Research Trust Fund. And if that is not reauthorized, it will have a direct and immediate hit on the agency as well, of about just under $100 million annually. So we think that, I hope you know that AHRQ is essential to meeting future needs, to address the rapidly evolving data sources and methods. I have to say, as an aside, my staff have heard me say this, but if you are, well, most of you are too young to remember this group called the Police and Sting. But there was this great song called "Every Move You Make, Every Breath You Take." I changed the rest to say, "is a data point." And all of that data needs to be understood for its uses to improve health and outcomes and healthcare delivery. We also have changing business and payment models. We need to understand, again, which ones are working and for whom. We are continuing to look at the rising costs of healthcare, and we have to continue to battle this gap between what we know and what we do, not just in one place, but sustainably, scalably throughout the country, so the right care is delivered to every patient at the right time, in the right way, and in the right setting. And then finally, we want to push for continued improvement in patient engagement in the research. So today we have 4 amazing speakers who are going to speak from different perspectives. I hope you all picked up a packet when you came in. Their more in-depth bios are listed there, so I'm just going to give you their titles. I'll go in the order that they will be presenting. Dr. Bundorf is an associate professor of health research and policy at the Stanford University School of Medicine, a Stanford Health Policy Fellow, and a senior fellow at the Stanford Institute for Economics and Policy Research and the Hoover Institution. So she's not busy at all. Dr. Hardeep Singh is professor of medicine at the Center for Innovations in Quality, Effectiveness, and Safety at the Michael E. DeBakey Veterans Affairs Medical Center and Baylor College of Medicine in Houston. And I would actually say that all of our panelists today are incredibly busy. John Wilbanks is the Chief Commons Officer at Sage Bionetworks and previously a legislative aide to Congressman Pete Stark. And certainly not least, but last to speak, will be Dr. Atul Grover, who is the Executive Vice President for the Association of American Medical Colleges and provides strategic leadership in many areas, but I like to claim him as a member of the AcademyHealth Board of Directors. So now, over to you, Kate.
Okay, thank you so much, Lisa. I think I will never forget Lisa Simpson equating a song written and sung by the Police to big data in the healthcare system, right? That's embedded in my brain forever. Thank you for having me, and thank you for this opportunity to talk a little bit about how AHRQ has been really fundamental for my research agenda. So what I thought I would do is just talk about a couple studies that I've done over time and the role of AHRQ in kind of encouraging or developing those studies. So when I was an assistant professor, I was very fortunate to receive a training grant from AHRQ for my early work, and that work was, or at least the work in the training grant was focused on health plan choice. So I had done some work as a graduate student thinking about employers and how do employers decide which plans to offer to their workers and what are the implications of that. And I was really interested in developing a kind of a broader agenda around health plan choice more generally. At that time, health plan choice was very important in the context of Medicare Advantage, right? People were choosing between the Medicare system, regular Medicare, and among the different types of Medicare Advantage plans available in their market. Since then, health plan choice has obviously become more important when we think about the development of Medicare Part D, where folks choose among private plans for their prescription drugs, and of course the Affordable Care Act with the exchanges, where health plan choice is also very important. So I did work, so I did receive this early career training grant from AHRQ to work on this. And from my perspective then, as well as my perspective as a more senior faculty now, I think I wanted to highlight some of the really crucial pieces or the crucial outcomes of that early career support for investigators. So the one that people talk about all the time is just to give early career investigators time to really develop their research agendas, like protected time to think very hard about the problems that they're interested in, and think creatively. It's like, you know, if you think about an assistant professor, you can roughly equate that period of your career to your 2-year-old, right? So you think about your 2-year-old, and they're learning so many things, and their brains are firing, and, you know, they're you know, making progress every day. Being an assistant professor as an academic is kind of equivalent to that period. Those things that you focus on and those things that you work on are really fundamental for the development of your future career. So protected time is important. I think the other things that are maybe less focused on that are also crucial about early career funding is it really makes you sit down and lay out your research agenda, right? So you're all excited, you come out of your PhD, yay, you know, we're ready to go. But you have to think very carefully about what you're proposing, because it has to go through the reviewers. You have to you know, tell senior faculties at your institution what you're working on, and that is very important as well. And then the final thing that I think is can be underemphasized is it creates this mechanism for people to identify and develop relationships with mentors, right? So these career awards require you to identify mentors. You have to go talk to them. You have to get their buy-in for their project. Just that process of identifying them makes you think about where you're going, what you need to get there, whose help you need, and then the formality of writing down those relationships and submitting them to a funding agency can really cement those relationships. So for those reasons, it's very important. So when I was working on my project, you know, I was very focused on health plan choice, and I was really interested in this idea of, well, there are these different types of plans out in the market, right? There are, you know, very tightly managed HMOs, right? So those have very low cost sharing, and there's kind of some centralized administrative structure from the top. And then there are these other plans out there that rely more on patient cost sharing to control healthcare use. And those seem like very different types of products, right? And how do people choose among those products, and how do we convey information on those products? And are we sure we're creating the right incentives for people to choose correctly? So I was walking around thinking about this, and I walked over to the economics department at Stanford, and I ran it across this idea, these things I was thinking about, across a very a star economist at Stanford named John Levin, who has since then gone on to win the John Bates Clark Medal. And John thought my problem was interesting, right? So I was very excited about that, and we ended up working on this project with this small data set to think about these questions. He brought in a graduate student from the economics department named Neil Mahoney. Neil is now a faculty member at the University of Chicago, working almost all his work is on health insurance and healthcare issues. So I feel like the opportunity to have the freedom to go around and talk to folks about this project was really instrumental in getting both John and Neil involved in this research. So we did a lot of interesting work. We thought about, well, we want to think about the risk of the people enrolling in these types of plans. We want to think about people's preferences, who would like, different styles of care. And we also want to think about the cost, right? And I'll just talk about a couple things that we found in that study. So one thing that we noticed is when we really looked carefully at the data, we focused on a setting where people were choosing among these two different types of plans. We noticed when we looked at the cost that HMOs had a cost advantage. They were cheaper, they were providing care, we think, more efficiently. But that cost advantage was really concentrated on people who were sick, people who had relatively more chronic conditions, than other folks. And that's where the HMOs were really kind of delivering their bang for their buck. On the flip side, when we looked at the contribution policies that employers were setting, we found that the way employers were setting contribution policies, not through their own incentives, but more through regulation, were not kind of steering people to the right plans. Like, we weren't creating strong incentives for the sickest among us to enroll in the types of plans that will really kind of manage their care effectively, right? So that was, and I still think that that's an important issue in thinking about the healthcare system and trying to create informed choices among consumers so they can really understand and have the right incentives to choose among different types of plans. Okay, so that was an example, I think, of the the opportunities that early funding or early career funding created in my case, and in the ability to bring in other folks who were interested in this area to work on them. I wanted to talk just a little bit about two more projects. One is a project that is just kind of wrapping up and was funded through PCORI. There was a lot of research that looked at academics really just love to point out where people are making bad decisions. We're like, oh, you should have chosen that plan. Why did you choose that one? You chose a dominated plan. It looks like it wasn't as good as the other plan. And I got a little bit tired of that research, right? By basically saying that people were making bad choices. And I wanted to work on a project to actually help people make better choices. So with funding through PCORI, we did kind of a full spectrum analysis of, we focused on Medicare Part D. Where there was lots of research that people were maybe not making optimal decisions in this context. So we started from talking to patients, talking to consumers, talking to pharmacists, trying to figure out where the problem points were, developing a tool in conjunction with our stakeholders to help people choose among plans, and then rolling that plan out in a randomized controlled trial. And in that case, when we really developed the tool with the patients in mind, we found that our tool was actually pretty successful. We were able to move people across different plans, move them into plans that covered their drugs more effectively, and helping people make better choices. Okay, I'm going to quickly talk about one more area of research that we're working on. This is funded by an R01 from AHRQ, and in this project it's a little bit different, but we're focusing on these incredible changes that we're seeing in the organization of the delivery of healthcare, right? So if we think about physicians are increasingly working in large groups. Sometimes they're multi-specialty groups, sometimes they're single specialty groups, and those groups are increasingly affiliated with hospitals. So we're using data that covers almost all of the US, trying to characterizing those groups and looking at the impact of those, the organization of different delivery systems across markets and how it affects care. I want to highlight this work because it's really, AHRQ is really one of the only homes for this type of work, right? So AHRQ goes across disease types. You can think about cost and value, as Lisa talked about, and those concepts are crucial for our research. And what we're doing now is really trying to think about how the organization of healthcare delivery affects cost and value in the healthcare system. Okay, thank you.
Good afternoon. Thank you so much for having me. And I'm going to be discussing our work on diagnostic errors in healthcare. Just a quick show of hands. Anybody from the audience has had a family member or a friend who has been misdiagnosed in the last 5 years? Just raise your hands. About a third of the people have raised hands just in this room alone. This is an important problem. I'm going to talk to you about a story first. This is Rory Staunton. He was a 12-year-old boy who presented to a pediatrician in New York. Was having symptoms of gastroenteritis, nausea, belly pain. He was throwing up. Was sent to the emergency room because he looked sick. In the emergency room, he was given some fluids and sent home after some blood tests. Next day, he got sicker and came back to the same emergency room. He was told he's really, really sick and he's going to be admitted to the ICU. 3 days later, Rory Staunton died from streptococcal sepsis. What was found on the assessment of this case was that when he presented for the first time, his diagnosis of sepsis was missed. He got fluids in the emergency room, but his blood pressure and his heart rate never got better. He also had a rash, which was a black mottling of the skin, but that was not really picked up by the emergency room. So there was a physical exam finding, but nobody sort of saw that. And then most importantly, he had a blood test that was suggestive of a rip-roaring infection, but that blood test was not picked up. It was missed by everybody, and we didn't find out till the next day when he came back to the same emergency room. Unfortunately, stories like this of Rory Staunton are not that uncommon. With AHRQ funding, we actually did the study to try to get an estimate how common are errors in diagnosis in US healthcare, and just make an estimation. Based on our estimations, about 5% of US adults every year will get a misdiagnosis. 5% is 1 in 20, and that amounts to about 12 million US adults that get misdiagnosed every year. Now, not all of these are harmful, not all of these lead to death, I must acknowledge that, but this is a very common problem. Now, there was a National Academy of Medicine report which was co-sponsored by AHRQ, which again made an estimation based on some of the numbers that I'm telling you, that said almost all of us are going to have a missed or a delayed diagnosis at least once in our life. So again, this is the National Academy of Medicine report, Improving Diagnostic Healthcare, came up with good recommendations on what we can do to fix the problem. Now, what have we been doing for the last 15 years in this area? Well, we've been really busy. We've been trying to define the problem of diagnostic errors. We've been trying to measure the problem, figure out why these things happen in healthcare, and then this would lead to actions to reduce the problem. Now, what we're trying to do, it looks sort of simple, but moving up that arrow is not. You need research to stimulate how to move from defining the problem to going up into action, and that's what we've been doing thanks to a lot of AHRQ funding. What has our early research shown? Well, one would imagine it would be rare things that would get missed, right? So the uncommon diagnoses and things like that. No, it's actually the common diagnoses that get missed. So it's things like cancers, infections, and cardiovascular conditions, heart attacks, strokes. All of these are the common conditions that get missed. Now, many of these are related to things not being picked up in the basic clinical skills, such as history and exam, listening to patients. All that time is getting really compressed and pressured. And so we're overlooking some of these red flag findings, and the Rory Staunton story really illustrates that. Typical emergency room, there's lots of chaos and interruptions, and you've got lots of sort of alarms going off, and you miss findings. We're also overlooking information which is already present in the electronic health record. So we've seen cases where supposedly somebody's chest x-ray was done 6 months ago, maybe a year ago. It's abnormal and nobody's picked it up so far. And so things are getting buried in these electronic medical records because we haven't been able to sort of find the finding that was abnormal from 6 months ago or from a year ago. And a lot of these things we're finding is the way the health system is structured and the way the healthcare delivery system works, it influences the way clinicians think. So if I have 10 minutes to see a patient in my primary care clinic, and if I have an electronic health record that is quite burdensome, I'm doing data entry, with all the documentation requirements, I'm not listening to the patient a lot, and I might miss something because I'm then getting interrupted from, something else. So it is really a time-pressured environment. So the health system delivery, the way we are structured, influences the way we think. That's a really important finding that we're coming up with. We're trying to create signals to bolster error measurement. So what does that mean? Well, measurement is the first step to improvement. If you can't measure it, how are you going to manage it? So you really need to try to figure out how do we learn about these errors so we can, identify the problem and fix that. So we've asked clinicians, but doctors really don't like reporting errors. So it's really hard to get, reports from doctors themselves about the errors they made. We have been able to do that, but it's hard. We can ask patients, and guess what? When we talk to patients who are misdiagnosed, one of the things they tell us is doctors didn't listen to them. That was the #1 reason why they got misdiagnosed. But what we've been trying to do with AHRQ funding now is trying to review these high-risk cohorts. So let's say patients with cancer, we found about 1/3 of patients with cancer would have some missed opportunity or a delay in their care. That's quite a high number, about 1/3. We've also developed with AHRQ funding what we call e-triggers, electronic triggers, which are essentially queries that can tell somebody to review the medical record to find some problem. Essentially, if you do this in a large, big data warehouse, you're almost like picking out needles from a haystack by making the haystack smaller and using a magnet to pull out those needles. So we really can take this to scale with electronic algorithms. Just example, if you've got a patient who is admitted, healthy patient coming to the hospital, rapidly deteriorates and goes to the ICU unexpectedly, we want to review that record. So that can that query would be applied to thousands and thousands of medical records, and we'll identify just the few that we needed to review. And that really makes the scale of finding these errors really, it takes it to scale. We can also identify patients through these e-triggers, patients who are having delays in their diagnosis. So if you have an abnormal test result, such as a chest x-ray, or it's a lab test, it's abnormal, it hasn't been picked up and followed up, we can develop these queries now to identify from electronic health records what to do next. Now, This research is not sitting on the shelf. It is actually being influenced a lot of work. So with AHRQ funding, again, we are trying to create these learning health systems, which are partnerships between the health systems as well as engineers and other types of researchers who can influence the way we structure care and deliver it better. And we call these learning labs. So essentially, these learning labs are ways to find and fix things, and that's what we're doing. We're also trying to create best practices that health systems can use to implement in their in their own setting. So how do you close the loop on an abnormal test results so patients don't get fall through the cracks of the healthcare system? We're trying to come up with strategies to engage patients. So for instance, patients should know about their test results. If you have not heard from your doctor, no news is not good news. So you got to go back and make sure that your test result is not abnormal. And then we're trying to use better use of electronic health records. So we're trying to make patient portals better, we're trying to make electronic health records better. All of this has been stimulated from initial AHRQ funding, as well as other funders that I'm going to acknowledge at the end. So looking towards the future, this is my wish list initiatives for the next 5 years for AHRQ. They have a lot of work ahead. I would really encourage AHRQ, along with the funding that they would get, to stimulate multidisciplinary research. Remember, the key is multidisciplinary. You've got to have clinicians working with other folks, psychologists, behavioral scientists, informaticians, engineers, to make the healthcare system better, and I'll give you examples of why. We need to measure and reduce this at a national scale. This is a national problem. It needs to be tackled on a national scale. And only an agency like AHRQ can do that. We then need to take all this research and implement that into real world practice and influence policy. Essentially, we don't want this research to be sitting on the shelf. So it's really important to translate this research into evidence. And there's a paper outside in a handout, which I would really encourage you to read. What we said was we did an assessment of the patient safety, what's the state of patient safety right now in the United States, and what have we learned in the last 20 years since the landmark report came out. Essentially, I don't know whether that's good news or bad news, we're still in the sort of the bronze age of patient safety. What we really, really want to do is to go to the golden era of patient safety over the next 5, 10, 15 years. And I strongly believe that an agency like AHRQ can help us do that. I want to thank my funders. This takes a village, the type of research I'm describing. So all the funders are listed on this slide. And I want to also, this is a team effort. So I want to acknowledge my team, a multidisciplinary team based out of Houston and Baylor College of Medicine and the Houston VA. So thank you very much for listening.
I have a very different story. Not being I'm not a life scientist or a health systems researcher, and I fundamentally come out of the policy world. I was here, long enough ago that I was here when HIPAA was written. So, and what I've been interested in is the way that we can use technology to affect policy, and use policy then to affect the technology in return. So 8 years ago, I started working on informed consent in the digital context. Looking at, in particular, the way that we sign agreements without paying attention to them. This is one of my favorite sociological studies in which people gave away their firstborn child in return for free Wi-Fi, because no one reads the terms and conditions. And this is a fundamental problem as we begin moving towards the golden age that Hardeep wants to get us towards, is if we're going to use phones, we have to accept the fact that people click OK on legal agreements between them and their goal. And this presents enormous problems culturally for simple consent, but it creates significant problems for informed consent to enroll people into medical research. One of the core benefits of a phone supposedly is that we will use them to enroll people. But if we know that people are socially conditioned not to click without reading, then we have to address that. This is not the kind of thing that NIH is good at funding. I work at a nonprofit organization that gets most of its funding from NIH. This is not a kind of project that leads to papers as naturally as a classic piece of R01 research. And so thanks to AHRQ funding the Electronic Data Methods Forum, convened by AcademyHealth, we received a small grant as well as in-kind support to do a really unusual project in which we did classic commercial style product design, which is to say ethnographic interviews with key stakeholders, user experience design and interaction design, looking at the problem of informed consent on a mobile device. And what we found is that everyone knew what the problems were with traditional consent, which is that we hand people documents written at a 25th grade level that are 25 pages long, and we give you 30 seconds and encourage you to just say yes because you trust us. So everyone knew that was a problem, but no one knew how to change. But there was a lot of support for this kind of design approach because it hadn't failed yet. And it didn't conflict with anyone's local incentives because it could sit on top of whatever your document was and create this interface. There's another problem when you do device-based reading, which is that people physically don't read the same way on screens that they do on print. So this is known as the F pattern, and if you look at languages that read right to left, it's a F in a mirror. We read across, down, across, and we read less and less text as the screen goes. So even if you were to present the document and someone were to stop and read it, they wouldn't physically read all of the words, but they would think that they had, right? So this is where I make a joke about culture, politics, and everything in the world right now. But it's really problematic when you're going to try to enroll people into a clinical study. And so what we came out of this was not an academic paper, but a set of designs. And this is not, again, what a traditional kind of funding stream creates. It's sort of the uniqueness of the ability of AHRQ to fund, and in particular fund into secondary groups like the CORI and EDM that can then make these kinds of bets relatively quickly. So could we create designs that slowed people down so that we could plausibly claim informed consent on a phone? And this is what came out of the AHRQ funding. I did this in PowerPoint, which is why it's ugly. But the idea was if you're going to enroll in a mobile research study, we might want to know things like, what's your gait like? And we would use the same sensors that you would use to turn your phone from landscape to portrait to do that analysis. So the idea was make someone do that on their phone as part of a consent process. We released all of this as open source because this is government money and this is the right thing to do with taxpayer funding. And Apple picked it up. And so this is now baked into Apple's Research Kit, which is an entire app-based framework for building apps for research studies. It's been used by at least 60 major research institutions in the United States, and it's enrolled about 600,000 people in those studies in the last 5 years, all using iPhones. After they got a hold of it, again, because it's open source, they can improve it. This is what it looks like post-Apple, where you have a navigation, you have a very structured area. We have this concept of an on-task picture, headline, and subheadline, which they've made much prettier. This is quantitatively shown to slow the eye gaze down to the same speed as print when you do eye gaze fixation tracking. Also, when you do reading comprehension timing, it slows people down to the same speed at which they read in print. Going past that, Apple baked this into their technical framework so that it's not simply something that they sort of recommend, it's part of their required workflow for building a research app. All the way through to the directions to the programmers, because I can tell you most programmers don't care about informed consent, the Belmont report, or any of these other things. They want engagement and users. And so having this now propagate all the way through into the largest lifestyle company in the world is a pretty remarkable success story for federal funding. This has kept on going and is paying off again. So as part of the 2016 extension of the Obama Precision Medicine Initiative into the All of Us research program, which is a much more complex study. It doesn't aim to just use sensors to get at whether you're walking correctly or not. It aims to pull in environmental, social determinants of health, biological and clinical data, and behavioral data into a 10-year study of 1 million American residents, at least half of whom must come from ethnic and racial minorities, and with a mandate to involve at least 75% of the million traditionally underrepresented in research across a variety of demographic variables. So blood, urine, longitudinal health records, genome sequences, linked data from census, air quality, everything you can imagine as part of this study to be made as publicly available as possible while keeping the participants safe. We were awarded the contract to develop the informed consent for this project based on the AHRQ work. And this is the sort of thing that wouldn't have existed under a traditional, we're going to investigate and write a paper about why consent's broken. This is what that project looks like now. It's too complex for the version that we built. We have to have videos that outline all of this key information. This allows us to immediately layer translations over the animations. So we've already launched this in Spanish, and we're now launching in another 7 languages over the next 3 years. All right, there's this whole process where this structured design sort of concept for consent that came out of this very, very small, very unusual and kind of edgy And if I had time, I would show you screen after screen after screen that shows that it works. So we don't really know what informedness is in informed consent. We mainly know it by its absence in most of what we do. So this is over 180,000 people who have consented into the All of Us research program. Just a basic question is what we call therapeutic misconception. It's a key problem in informed consent. People think that the research study is treatment. It's a classic mistake. Most of the review papers show that on average a traditional consent process gets you 40% accuracy on this question. As you see here, we're in the 90% accuracy on this question. This is showing it across education. So you see a very mild gradient, but again, the worst of these are in the low 90s, the best are in the high 90s. We see these numbers propagate across all the questions we ask as part of consent, across all ethnicities, ages, income levels, education levels. Every demographic we can get at shows that if you spend the time to talk to people and design for them to be informed about choices, they understand it. But it takes a design process, and that's the sort of thing that healthcare research and quality investment leads to, but biological research doesn't. And venture capital doesn't fill this hole. Traditional funding streams don't fill these holes. They don't let us research a product that implements a policy and then see if it works or not, and then give it away so that it can grow. So just one quick story of what AHRQ can do that other agencies can't do, and the impacts that that has had. Thank you.
Good afternoon, everybody. Thank you for being here. I am going to try and wrap this up a little bit to wrap your brains around how all this stuff kind of fits together. For me, that's always been a challenge, is figuring out, what do these different agencies do? What do the different researchers do? And how do they get it done to advance health and move it forward? So I want to talk a little bit about what we do in our institutions, why that's not showing up. Oh, okay, well, I guess that is a different slide. We are about 154 MD granting medical schools in the US, 17 in Canada, about 400 teaching hospitals and health systems, including partnerships with VA medical centers, as well as 80 academic societies and faculty. So these are the people that are out in institutions that you often think about doing work to advance basic biomedical research, right? So go down the street here, Hospital Center, Hopkins, Georgetown, University of Maryland, Howard. Those are our members. Now what's interesting is that those 5% of hospitals represent almost a fifth to a quarter of all the clinical care delivered. And in fact, a disproportionate amount of care to those who are underserved, whether they are uninsured, underinsured with Medicaid, or those who have really complex or acute severe medical illnesses. We also do over half of the funded research out there. NIH is probably the best data we have in terms of the share of funding and train the future's healthcare professionals and biomedical researchers. So we kind of have a view of all of this stuff, but I wanted to talk just about a couple of examples where AHRQ has funded work in these institutions. My disclaimer would be, yes, I'm on the AcademyHealth board, I'm paid by the AAMC. I was trained to do lab science by the NIH early on in my career. The Health Resources and Services Administration helped support my funding as a primary care physician. And AHRQ, and actually its predecessor, AHCPR, funded my training as a health services researcher. So I am living evidence that all this stuff has to fit together somewhere outside of an institution or a lab. And a couple of the recent examples that I thought were relevant and interesting, AHRQ has funded the University of Colorado as well as a bunch of other state public health departments to look at rural treatment of opioid disorders and pain disorders. And in Colorado in particular, I think they're up to 20 rural counties now where they've partnered with clinicians to train them how to do medication-assisted treatment that's generally with Suboxone or methadone in addition to behavioral therapy, because again, we know that this stuff works, but how do you get it out there? How do you get it into the hands of clinicians, and how do you actually improve the health of the community? So I want you to think about this as a continuum between advancing basic science, figuring out what works in the laboratory, to what works at a bedside, to what works in a health system, to what works to actually improve the health of a community. And importantly, we're increasingly thinking about how to make sure that those improvements are felt in a community across all populations, right? How do we get at health equity? That's not something that basic biomedical research is necessarily thinking about on a day-to-day basis. Another example would be the work that many of you are aware of, Peter Pronovost, who is at Hopkins for a number of years. Peter did a landmark study that was funded by AHRQ looking at the decrease in central line infections in hospitals. And so while Gopal talked about the advancements that AHRQ is leading in primary care, AHRQ really helps us advance care everywhere, at the bedside, in the critical care unit when it comes to things like central lines. And this is something I saw as a clinician, as somebody who worked as a hospitalist, to see, we learned that, guess what? We put central lines, these are big veins, big catheters that go into veins when I need to give you some, increasing boluses of fluid if you're very, very sick, or things that have to go to the heart or the lungs more directly. I don't put them out here. Hate to tell you this, hope you never have to have one, but you put them in here, or you put them in here, or you put them in here. Turns out the groin is a very dirty place. We needed to figure that out, okay? So the first thing that happened is we stopped putting central lines down there because the rates of infection were intolerable. And in Michigan, the work that this group did brought down the Keystone Project central line infections, the median rates, to essentially 0. The average rates were also down, not quite to 0, but it was significant. And I actually was working as a consultant back in the early 2000s, saw this work being done not just in Michigan, but being advanced at the national level by Peter Pronovost through the work at Hopkins and their research institute, but also I saw it in Western Pennsylvania with the Pittsburgh Regional Healthcare Initiative. So all these communities were slowly figuring out how to do these things better. We at the AAMC, again, we're not doing basic research, our institutions are. They're also increasingly interested in the health of those communities, as I mentioned. So one of the things that AHRQ has funded is a collaboration between 10 academic medical centers that are interdisciplinary and community-based. How do we actually improve the health of populations in communities with community partners, including public health and other stakeholders? So 10 institutions have come together to figure out how to have an interprofessional workspace to do this work, to develop implementation plans that are closely tied to the community health needs assessments that were passed as part of the ACA that all hospitals and health systems have to do. And what that's led to is, again, improvements in not only individual healthcare, but community healthcare. And it's actually changing some of the way that our organizations are organized, so that we now have C-suite level people who are responsible for improving community health and decreasing disparities and improving equity. That's new. I wish we had been doing this before. It's just not how we were designed. And so I think it's critically important to think about where all this stuff fits together. If you think about, and you'll hear these terms of T0, T1, T2, T3, really, if you look at the circle from top around in a clockwise fashion, it's really talking about moving from the bench work that I was trained in the 80s to figure out, how do these different pathways work, to figuring out how we then make sure that any drugs that come out of that, devices, therapies, are developed safely for human patients, to figure out how we put them into clinical trials to see what's effective. We know what's effective for a patient. How do we figure out what's effective for a community? And that's where the work of AHRQ comes in. And also, as Lisa mentioned, the work of the Patient-Centered Outcomes Research Institute, PCORI. All of this stuff hits in T3-4, where you're trying to figure out how to improve the health, not just of an individual patient in front of you, but of a population. And I think, one of the things that we talked about was moving from the Bronze Age of patient safety. I mean, we've got all these data analytics now, we've got genomics, we've got all these things, but we have to figure out how to get them into people's hands and to change the way that the system works. That's where AHRQ comes in. It's not about developing the next pill, it's figuring out how to improve the health of the population through the use of those pills, and really frankly training clinicians like me to ask the right questions and to care for the people that come into my office. So I'm going to stop there and turn it over to Lisa. She gets the hard part of the Q&A.
Thank you, Atul, and thank you to each of you for your great on-point presentations. So I think a clear message across all of the presentations is, I'll go back to something that Director Khanna said, is that the two sides of that coin are cure and care. And AHRQ is very much focused on that care side. As technology, as innovation, as basic science discovers those cures, the reality is they're not translating into care that you and I can get tomorrow. And so this work is absolutely essential to shorten that time and invest in that care dimension. And Hardeep put out, Dr. Singh put out a lovely sort of wish list for the next 5 to 10 years. I'd like to ask our other panelists, what would be your wish list for the next 5 to 10 years? And I know Atul is very nimble on his feet, so I'm going to give him the first go at that, and that'll give Kate and John another chance. But I also want to invite members of the audience to stand up and or raise their hand, and I will call on you. And we have a microphone for the Facebook Live. You can be on Facebook Live to ask our panelists a question.
You didn't tell me this is the way you treat your board members.
Combat pay.
I think one of the challenges, the frustrations that we have as clinicians and people who are trying to detect, develop, deploy the latest cures in technology, whether it's CAR-T, individualized, personalized medicine, is figuring out how all the data comes together. And for us, we see the EHR often as this inhibitor between the physician, the clinician, and the patient, but very few clinicians, I don't think anybody would tell you they want to go back to paper, right? Not want to go back to paper. And I remember, God, you know, like next to the Department of Radiology, the Department of Medical Records is like the most infuriating place in a hospital. Right? So we've skipped that piece, but the challenge is the data now sits out there in so many different places. And I think about interoperability. I know that we're thinking about how to transmit that data safely with privacy concerns. But we've got to figure out how to really harness that data in a way that we haven't before. I know that our clinicians are now spending their big spends, electronic health records, Epic and Cerner and others. These are billions of dollars they're investing, and we haven't figured out how to actually harness that information. So I'd like to see AHRQ help us with trying to figure out how all that data gets connected.
And that's particularly timely because not only is this year the 20th anniversary of the agency, it's also the 10th anniversary of the passage of the HITECH Act as part of the American Reconstruction and Reinvestment Act, which was what funded the investment for EHR. So that was sort of, let's deploy. Now we have to figure out how to optimize because we're not there. And you've all heard about the burnout issues. So I think AHRQ has a critical role to play in figuring out how to optimize these new data in the workflow of care practice and make sure we don't have more errors as part of one of the side effects. John or Kate, who wants to go next?
Sure. So there's a lot of money that's being invested in precision medicine. So it's happening at NIH, it's happening in the private sector. There's not a lot of research into what I would call what's the opposite of precision medicine would be like bulk health. And there's an enormous amount that can be gained in bulk health investment that's not likely to come out of the kinds of systems that we've got because it doesn't lead to reimbursable outcomes. It leads to things like, you know, eat less and exercise. And I view the consent work that I showed as an example of an eat less and exercise kind of intervention, right? Slow people down and make them think and pay attention to teaching them teaches them better than not doing that. It's kind of obvious. But the systems that we've got are not set up to fund those sorts of things. And I think that you'll see this up and across the system. So in particular, as we start to see private systems using machine learning and artificial intelligence that are addressing biased data sets that will find and reify structural problems of racism, misogyny, and denial of care, right? There's a role for this agency to make sure that there are public unbiased training sets that we can use to identify biased analytic systems and predictive systems, as well as to identify, you know, lower tech interventions that might not be as reimbursable, but that would have disproportionate health benefits in communities across the country. And AHRQ is fundamentally set up to be a part of that in a way that a lot of the other funding streams aren't, just by, not because anyone's bad or good, but because of the way that we structure and fund things. You know, I've been here. You have to figure out how to define a thing so that you can write it down, create it, or regulate it, and fund it. And AHRQ sits at a spot where if it doesn't exist, a lot of the sort of bulk health and public health work and health systems improvement work that we have sitting on the table that would have dramatic impact is going to go undone. And so it plays just a vital role. So I would want to see in those 5 years just A, keep it alive, right? But B, really focus on the impact of programmatic and predictive analytics on healthcare to make sure that that is as fair, just, and beneficial to as many citizens as possible.
Great, thank you, John. Kate?
Yeah, so I think I'll reinforce to the messages that Atul and John talked about, and then add one. So one is this issue of interoperability, connectedness, and representativeness of data. This is hugely important. There are not private sector organizations that are so interested in these public good types of questions. And if we are going to balance the benefits of interoperability with the risks to patients of privacy, we need people who are kind of in the taking a public sector perspective to think about how to do this. So I think that's incredibly important. This is one thing in our, just one little example that we worked on in our tool with Medicare Part D folks. It was very hard to get their data into a tool, their personalized data into a tool through existing regulation. That existing regulation has some benefits. It helps people keep their data private. So how to navigate that road, I think, is incredibly important. I think the other thing I would emphasize is kind of the role of basic science in delivery system research, right? So we have a lot of research that is targeted on very specific problems, but I think it's important to make sure that we still have a role for investigator-initiated, very original, like the breakthrough of healthcare delivery type of research, right? The things that we haven't even really thought of yet. So we can't really target our resources, or our calls, or our funding requests there because we haven't thought of them yet, right? So we need some kind of open mechanisms for junior investigators, senior investigators to come up with their kind of best ideas and do that kind of very basic research that helps our healthcare system function.
And don't worry, Hardeep, I will give you a chance to also speak up, Dr. Singh. But I wanted to comment that I was really pleased that Dr. Bundorf was able to tell us about the role of AHRQ in training. And I will, full disclosure, not only was I former director, but I was a former trainee of AHRQ when I did my postdoc at UCSF in, let's just say, early 90s, and how important that is to really shaping the workforce of the future. And AHRQ has also invested in training for learning health systems most recently. Again, this intersection of how do systems deliver care to individuals. And that's a really critical piece that it's very hard for, I don't see other agencies really focusing on that intersection. And then, of course, as a person who raised her hand with a diagnostic error, also personally experienced that in terms of a misdiagnosis for 6 months. But final word, last comment, since I'm not seeing hands going up here in the audience. Oh, one hand, great. The microphone is coming with our own very version of Vanna. Phil Donahue, got it.
You mentioned a little bit earlier about the importance of interoperability and the ability to collect large sets of data. I was wondering what you think are some of the most important obstacles to get past to achieve that. Is it EMR systems? Is it competition among health systems? Is it funding or privacy concerns?
Yes. Yeah. I mean, they're identifiable, they're tackleable, and I think it's as Kate was saying, there's not a private industry that's really incentivized to go after these problems. So it's where it becomes the public good that government needs to help support. I think we're trying to do it now, but even there's really challenges. If you look at health systems that we work with, where they're on the same system. In affiliate institutions, they're on different versions, kind of going from 1.0 to, and they don't talk to each other. And then you've got all of the legal issues. And the question is, I like the bulk care concept as the opposite of precision medicine. But the other thing that's the opposite of precision is imprecise medicine. And we're at risk of being very imprecise if we don't harness this data. But each of those things you listed are all obstacles that all have a solution. But the challenge is, as Kate said, there's nobody out there that's incentivized to do it.
And you believe all those solutions can come from the public sector?
I think they can come through public-private sector partnerships, but somebody has to, and I really applaud AcademyHealth for doing things like Health Data Palooza, trying to bring the different sectors together, and that's not my area of expertise, but certainly now as you see Apple and others getting into wearables and developing their health platforms, I mean, for goodness sake, if you've got Google and Verily and the money's out there. We just have to figure out how to incentivize this correctly in a way that's safe and feels like it protects the privacy of ourselves and our loved ones, right? I think that's the challenge. And I know in the hearing in the health committee last week or this week, Senator Alexander talked about this, and there's a group in Nashville that's working on some of this as well. So it's doable, but it's going to require just as much of investment as we did in the original HITECH Act.
And even if we make progress, which I'm always an optimist, we will, we then have to also study and monitor that progress, because when we launched the investment in EHRs and all that, we didn't know what kind of unintended consequences we would have. And that's the kind of research that AHRQ sponsors, to make sure that how this policy, this investment plays out is actually how you had hoped, and its distributional impact across the whole country. Well, with that, I want to thank you all for joining us. I want to take the prerogative of the chair to say that the last word, which is the Agency for Healthcare Research and Quality is an essential and lead agency that without it, we will not achieve better care at lower value. So please don't forget that in all of your visits here on Capitol Hill and as you talk to your stakeholder partners. So thank you very much to our panel, and thank you for joining us.